In 1991, after almost 70 years as a single-party state run by the Communist Party, the Soviet Union collapsed and 15 new countries emerged.
The collapse of the Soviet Union had cataclysmic effects for the republics that emerged from it. Here you had one superpower breaking up into 15 independent states. So politically, those states had to get to work writing new constitutions, putting in place political institutions, parliaments and the like, designing a new flag in some cases, developing national anthems, postage stamps, new currencies, all sorts of things. The economic consequences were really quite grave because they had been part of one integrated trading bloc, and those trading relationships all broke up. So the companies, the firms that were making them faced enormous financial problems. Socially, that had huge consequences because those firms went bust in many cases. They could no longer compete on the international markets. At the same time, many of the poorer republics had been heavily dependent on subsidies coming from the richer ones, such as Russia and Ukraine. Those disappeared, and that meant that the social safety nets were torn apart. The health systems that had been in place collapsed. The social systems, pensions were no longer paid. There was no access to medicines. It was a huge problem.
Suddenly, people lost their economic stability. They had a huge, what we call transition stress, not coping with everyday life because not knowing if you have a job the next week. In the Soviet Union, for 70 years, nobody was ever fired. There was no concept of unemployment. And suddenly, the head of household, the father, who was a coal miner, lost his job and was sitting at home in depression and dying.
While some commentators hailed the transition as one of the great success stories of 20th century politics, others have focused on the devastating consequences for health. Across the region, the transition had an immediate and largely adverse impact on health. UNICEF attributed more than 3 million premature deaths to this rapid change. Over 10 million men are missing because of this system change, according to the United Nations Development Programme.
The life expectancy of men in these countries fell dramatically from 65 to 55 years within a few years. And it was a puzzle because nobody knew why it was. Normally, after a war, after the end of an empire, you have lots of death because of infections, because all the systems are breaking down and people get infected and die. But this was a mortality crisis on the basis of not infection, but basically cardiovascular diseases, heart, stroke. And this was a very new type of health crisis, but very deep. It was, you could see tens of thousands of men dying, not with 68, but with 45.
At the same time, in some of the republics, you had a collapse of the healthcare system. So those people who had been dependent on healthcare, for example, people with insulin-dependent diabetes, were no longer able to get their medications. And we saw a rapid increase in deaths from diabetes. We also saw a breakdown of the disease control systems. So we saw an upsurge in deaths from tuberculosis. We saw an epidemic of diphtheria. We saw malaria coming back into some of the southern republics like Tajikistan and Azerbaijan from where it had previously been eradicated.
It was clear that more information was needed to fully understand why the transition was having such a devastating impact on health. So 10 years after the collapse of the Soviet Union, a group of researchers funded by the European Commission undertook a new project. Their study was unlike any that had taken place in the region before, and it was named Living Conditions, Lifestyles and Health, or the LLH.
The LLH study was aimed to analyze the health situation in the former Soviet Union, how people live, the lifestyle, how people are drinking and eating, and public health in general. And our innovation was to have a large-scale comparison between 8 different societies in transition. What we found is, first of all, the lifestyle in this area in terms of eating and drinking and smoking was not very positive for health in general. But in addition to this high level of alcohol usage and high level of cigarette consumption and high level of unhealthy food, a lot of fat and other things, in addition to that, we had also the crisis of poverty.
In the years following the LLH project, the situation in these countries changed considerably, although not in a consistent way. Most of their economies were growing, and in some cases very rapidly, as a consequence of exploiting natural resources such as oil. However, the benefits were not shared by all, and though the share of households living below the poverty line has fallen since the early 1990s, incomes have become much more unequal. The researchers wanted to monitor the changes that were occurring in the region in terms of health status, behaviours and lifestyles, so they embarked on a follow-up project. It was led by the Institute of Advanced Studies in Vienna, the University of Aberdeen and the London School of Hygiene and Tropical Medicine, but it involved 13 partner organisations in total, 9 of which were from the study countries. It was again funded by the European Commission, and it was called Health in Times of Transition, the HIT.
The HIT study fills a very important gap in providing information about exposure to smoking, alcohol consumption, diet and nutrition, but more than that, this is a very innovative study in that it also has information on the communities in which people live, their living conditions, so we can look not just at the causes of disease, but the causes of disease.
The HIT followed a similar outline to the earlier LLH project to allow comparability, but it also made use of new methodologies. So alongside the repeated household surveys, the researchers analysed the communities where people live, perceptions of health among adults and children, media influences, tobacco and alcohol industries, and the health systems of these countries.
And this was a pioneering study, huge household survey in post-Soviet countries, approximately 2,000 respondents per country, 18,000 respondents everywhere. We implemented series of focus groups about health and healthy lifestyles in Russia, Ukraine, and Belarus, including Chernobyl area. It was very topical, series of expert interviews and so on.
Исследование, как и у всех других стран-участников проектов, состояло из количественного и качественного исследования. Это был массовый опрос по репрезентативной общенациональной выборке, по различным вопросам, связанным со здоровьем, политикой, образом жизни, социально-политическими вопросами. Также это были фокус-группы, как часть качественного исследования, а также community profiles. Это то, что мы как раз очень трудно перевести на русский язык. Да, это очень сложно, действительно, потому что, как это ни странно, несмотря на то, что Советский Союз в течение 70 лет пытался строить коммунизм, где корень этого слова как раз community, да, то communal, у нас были коммунальные квартиры, но такая вещь, как community, на русский язык, в общем-то, не переводится. Нам приходилось подыскивать специальный термин, и мы не могли найти, в общем-то, ничего лучшего, чем брать как вот поселение или населенный пункт. Хоть это, конечно, не то же самое. И надо было долго объяснять тем, кто выполнял наши обследования, кого же мы хотим, что же мы хотим изучать и что это за локация комьюнити. Вот это была действительно большая трудность.
Aside from the difficulties of translation, conducting a study in this region is not without challenges. Although countries now have stable governments, tensions persist, and the region remains susceptible to conflict. The HIT project surveys were delayed in Kyrgyzstan by the civil disorder that erupted in 2010, as the Kyrgyz president was ousted and ethnic tension between Kyrgyz and Uzbek populations in the south escalated into violence.
Но первые сложности в основном это были у нас связаны с Кыргызстаном, потому что я говорила, что была сложная политическая ситуация в 2010 году. И мы даже сомневались, сможем ли мы вообще проводить там исследования и насколько эти данные будут корректны, потому что ситуация была непростая, народу была очень сложная тоже ситуация, потому что мы же изучали именно условия и образ жизни, качество здоровья населения. И поэтому нам было очень важно, чтобы это была ровная ситуация для того, чтобы народ был готов и был открыт отвечать на исследования. Значит, в Казахстане есть своя немножко ситуация, потому что мы, в принципе, достаточно экономически и по всем другим вопросам уже продвинулись. Но, с другой стороны, есть какие-то нюансы, когда люди по-своему уже стали закрыты для таких исследований и не всегда готовы свои данные, потому что, может быть, где-то даже сомневаются, что кто-то интересуется их образом и условием жизни, их здоровью.
The first step of the project was to speak to people living in the region and to examine the communities in which they live. This involves structured interviews with 18,000 individuals across the 9 study countries.
В анкету блок тем, прежде всего, это проблемы, которые связаны с пониманием здорового образа жизни, темы, которые были связаны с удовлетворенностью работы системы здравоохранения, с уровнем оказания медицинской помощи, с проблемами питания, алкоголь, курение, и блок такой более социальный, еще более, вернее, социальный, это блок, который был связан с социальным капиталом, с некоторыми политическими проблемами в данной стране. Вот примерно так.
These household surveys with randomly selected individuals allowed the researchers to take a nationally representative snapshot of health status and risk factors in the region. The researchers also examined the communities where these individuals live to better understand the way that local environments shape health behavior. The interviewers were trained to observe and document the characteristics of each town or village, using a mixture of written observations and photographs.
Существовала определенная инструкция. Наблюдатель должен был выполнить 3 задачи, основные и главные. Первая задача, он должен был зафиксировать самостоятельно разные проблемы, которые связаны с данным населенным пунктом, с его местоположением и так далее, для того, чтобы можно было идентифицировать этот населенный пункт с другими. Второй нюанс, который делал наблюдатель, он должен был хорошо и глубоко разобраться с тем, что на этом маршруте есть, поликлиники, магазины, социальные учреждения. Он должен был сделать фотографии зданий, таких, так сказать, основательных и хороших, и плохих, должен был посмотреть на дороги, должен был определить, какое расстояние от средне находящегося жилища до поликлиники или до больницы, ну и так далее, и так далее. Вот это все должен был делать наблюдатель. И третий момент, он должен был пройтись в течение 40 минут по данному маршруту, посмотреть цены в магазинах, посмотреть рекламу, посмотреть, какие товары продаются, ну и так далее. И все это фиксировалось в специальном дневнике наблюдателя.
What we did is when we were conducting the household surveys and the community profiles, we also systematically took photos of certain features of the environments and the communities where we were collecting the information. And what those photos provided was firstly an understanding of the context in which we were collecting data, but also importantly it enabled us to objectively and systematically quantify features of the environment and look at how those features of the environment then impact upon health.
The results of the household surveys and community profiles provide us with an understanding of key issues for the region, such as tobacco, mental health and access to care. The household survey collected comprehensive data on smoking in the region, the determinants of tobacco use, public knowledge of tobacco's health impacts, and public opinion on tobacco control. Smoking in the region is widespread. Around half of males are smokers, and female smoking rose rapidly following the collapse of the Soviet Union. Contrary to what is often claimed, the household surveys uncovered substantial support for stronger tobacco control measures. Almost 80% of people thought authorities were not effective enough or could do more to fight against smoking. More than half thought tobacco prices should increase, and almost everyone supported some form of restriction on smoking in social spaces, with over a third supporting a total ban. The survey also revealed very poor knowledge of the health impacts of smoking. A third of respondents did not know that smoking causes heart disease and bronchitis. Although tobacco companies claim that smokers make an informed choice to smoke and are aware of the health risks, the results showed that smokers were significantly less likely to know the health risks than non-smokers or former smokers. These results are further supported by the photographs that were taken as part of the community profiles.
We also took detailed photographs of the packets of tobacco in these communities, and then did detailed analysis of how those packets conform or often do not conform to national legislation and international legislation. So what the photographs of the cigarette packets also provided was really interesting information around prices and the exceptionally low prices, which goes against all recommendations regarding tobacco products. So in some areas, tobacco products and packets of cigarettes were as low as a packet of chewing gum. The photographs also revealed the ways in which tobacco companies are still using misleading labels on cigarette packets, such as lights or mild, which again goes against many international agreements and national agreements from the government. And so this provided objective proof of the way in which these misleading labels are still being used across the region.
Alongside tobacco use, alcohol consumption is one of the main causes of ill health and premature death in the region. Another key part of the HIT project was a stakeholder analysis, which explored public debates on the regulation of alcohol and tobacco, the players involved and the positions they defend.
What's meant by stakeholder analysis? You try to understand who is influencing the tobacco and alcohol market, and in what way, and what are the goals, what are the KPIs, who pays them to do it, how influential they are. So that's what you're trying to map. But actually the research we've done was slightly broader, because we looked at not just at stakeholders, but we did analysis of the public opinions of the legislation, etc. So it was slightly broader scope, I would say.
The stakeholders included the alcohol and tobacco industries, governments including the Ministries of Health, Finance, Trade and Agriculture, NGOs and experts sponsored by and independent from industry. So what were the findings of the stakeholder analysis, and how can they be used to influence policy?
Vodka is something so Russian, it doesn't get any more Russian than vodka, actually. So how do you make sure that people don't drink in huge quantities and don't kill themselves by doing so? And obviously the alcohol producers, the local ones, they have a lot of lobbying powers. It's an important part of the economy. And all of those countries, we've done the stakeholder analysis, and they're struggling because they want to achieve economic growth, they want GDP to double in 5 years, etc. And it's very hard once you're starting to choke even some industries, even the marginal ones. And alcohol and tobacco are not really marginal industries, they're quite part of the GNP and GDP, but they're a hazardous part of that. So whenever you basically read the laws, you see this conflict of interest, because on the one hand, the governments want economy to grow, and they say, oh, that's an important part of the economy, we can't just kill it. And on the other hand, they want to do something about health, and it's a very hard trade-off. So what HIT contributes, basically, it shows what are the potential buttons one could press in order to shift this kind of trade-off towards health.
The stakeholder analysis also revealed tactics used by the tobacco and alcohol industries to discredit those fighting against them.
For instance, one thing which emerged in all of the 6 countries, tobacco industry would find a funny clown in politics and would pay him to pretend he's fighting with the industry, but do it in a very stupid manner so that everybody will think, oh, this anti-tobacco movement is totally stupid, we don't want to be associated with that. And it emerges in all of the 6 countries that there is somebody coming and saying, oh, we need to shoot all the smokers and so on. So it's very hard to do anti-tobacco work after that, because everybody will just think you're insane and will associate you with this politician.
Alcohol and tobacco are key causes of premature deaths in this region, and the prevalence of these high-risk behaviours increased dramatically with the collapse of the Soviet Union. Another crucial public health issue is mental health. For many, the transition period was a traumatic experience. People were plunged into uncertainty as the ideology and relative stability they had grown up with was abandoned. Using the household surveys, the researchers were able to quantify the prevalence of mental health problems in the region and monitor how this changed between the LLH study of 2001 and the HIT study of 2010.
Well, I think we recognise that the impact of the transition had major impacts on all aspects of health, including mental health, perhaps particularly mental health. And so what we did was we developed a scale looking at a range of different symptoms related to mental health, such as loneliness, stress, feeling depressed or low, and then produced a summary score that allows us to in some way quantify levels of poor mental health amongst the population. Well, what we've shown is quite strong evidence that there are winners and losers in terms of the improvements in mental health across the region. And really those people that are most economically deprived or socially marginalised haven't experienced the improvements in mental health compared to the better off.
Another important issue for the region is access to care. During the Soviet era, all countries had similar health systems that provided nominally free care at the point of use to all citizens. But since transition, these countries' health systems have diverged dramatically. Access to care remains poor in the region.
Well, importantly, we asked the general population rather than just those that actually end up in a healthcare facility or a hospital. And what we really found that while there have been some improvements over the past decade or so, there are still major gaps in access to healthcare, with a significant proportion of the population not accessing healthcare when they felt they actually needed to access healthcare. And this was principally due to financial reasons, not being able to afford the healthcare, or not being able to afford the drugs that are required to provide the adequate treatment. Well, what we've really found is a lot of it relates to impoverishment and lack of access to funds to pay for care. And that may be formal costs for healthcare, or it may also be informal costs for healthcare, i.e. having to pay a doctor or a nurse to receive the adequate type of treatment that's needed. But we're also suspect that it's also related to problems of information about accessing care, the information that doctors or nurses are providing to patients. So in the case of hypertension, there may be problems around the prescription patterns, the advice that people are getting about taking their treatment regularly. But also more broadly, it's about understanding healthcare conditions and when people should be going to a doctor or health facility for treatment. So there's widespread ignorance around a lot of key health conditions and symptom signs which should push people towards getting access to care.
Access to care is clearly a problem in the countries of the former Soviet Union. To gain a better understanding of the ability of health systems to meet population needs, the researchers also carried out a multi-method evaluation of health systems, using the example of diabetes care. In Armenia, Belarus, Moldova, Russia and Ukraine, interviews were carried out with key informants, healthcare providers and patients with diabetes, to assess the barriers that patients face.
In the HIT study, we're doing a lot of work looking at statistics. We're collecting survey data, but we're also talking to ordinary people. We have focus groups, we have interviews. We're trying to understand how the data that we collect impacts on the day-to-day experience of ordinary people. And yes, we have many stories that help us to capture that reality. In a way, what our work seeks to do is to put some flesh on the bones of the epidemiology.
Diabetes care is a good indicator of how well systems work, because effective management of diabetes requires a lot more than insulin. Since 1991, death from diabetes among people under 50 has increased about 8-fold in some parts of the former Soviet Union. Something has clearly gone wrong. Diabetes care needs a system that will enable people at risk of complications to be diagnosed and treated early by health professionals who know what they are doing. But the reality is different. The interviews from Armenia, for example, attest to the struggle of patients to find adequate care and the challenge for providers to offer it. One of the women interviewed had her foot amputated because of complications that could have been prevented if her diabetes had been better managed. As if this was not traumatic enough, she also had to pay around $1,000 for the procedure.
After learning that I had been lying down for 15 days, the doctor became angry that those wet wraps didn't improve my wound. The doctor opened a hole from side of my big toe and just poured some medication into the hole. I don't recall what the medication was, but it cost around 12,000 drams. After that, he realized that my foot was not responding to his treatment. He told my son that we should go to see another doctor. He said that my foot would have to be amputated, so I was taken to a Republican hospital, where an old doctor checked me and said that he would not touch a diabetic because it was very dangerous and something could go wrong.
Amputations need not be part of the experience of patients living with diabetes. Unfortunately, however, this is a situation all too common in many middle and lower income countries. In Armenia, the combination of poor logistics, lack of government commitment, and a shortage of funding for the healthcare system means that providers cannot always provide the care or the materials they need to keep patients healthy. We only provide them with some insulin, not all, and without syringes too. They have to go and pay for those themselves. When we have two different insulin from the same company, we tell them to inject it at once with the same syringe, but it's contraindicated to do this, especially when there are various brands of insulin from different companies. It causes complications, resistance, affects the immune system and other things. The patients spend a lot of cash on the syringes. Each month I request 1,000 syringes along with the medication, but until today I've probably only received about 100 syringes. None of our patients uses a single-use syringe only once. They inject with the same one so many times until it becomes blunt. These interviews provided brutally honest accounts of the everyday lives of people struggling with the health systems in these countries. Diabetic patients have direct experience of the way health systems work.
Actually, diabetes is interesting from this perspective because it is a chronic condition and requires quite treatment throughout a long time. That means that the patient has to come into contact with different parts of the system. That's why we use this condition as a tracer to look at how the system performs. In some countries, we notice that patients with diabetes care directly approach to the secondary care, which is not a best practice of diabetes management. Physician as a primary care should take care of the patient and in case of complications refer the patient to the upper level. And once the patient takes care at upper level, the information will come back to the primary care level to have a holistic picture of the patient's treatment and follow-up. So that's totally distorted in these countries. The problems which we identified through our study, it will be a pattern for the whole system. So diabetes is not a unique, it's not like a defragmented from the whole system. For example, problems with drug supply, with infrastructure, with physical inputs and intellectual resources. So that will be like a characteristics of the whole system.
If the system fails due to these problems, patients suffer avoidable complications and die. Looking at diabetes care through the multi-method evaluation tool provides an important perspective, not only on how well health systems in the former Soviet Union are performing, but more importantly, on what needs to be done to improve them. The countries in this region have undergone major transition over the past 2 decades. Since the collapse of the Soviet Union, they have seen continuing development of governance and institutions, but clearly there is still progress to be made. So what does the future hold for the region?
My views on the future in this region are somewhat mixed. We have seen some improvements. In Russia, life expectancy has now been improving for about 6 years, and that's the longest sustained period of improvement in the last few decades. On the other hand, in other countries, we're not seeing those gains. I think that the challenge now lies with the governments to see if they have the willingness to address some of these major threats. And unfortunately, some of them are in a better position to do this than others. So I think what we're probably going to see is a greater divergence as some begin to pull themselves out of the challenging situation they find themselves in, but others I think are less capable of doing that.
Вот. И сегодня трансформационные процессы, они до сих пор у нас еще продолжаются. И в Кыргызстане, конечно, совсем другая ситуация, чем в Казахстане. Но при этом, при всем, еще не все мы живем достаточно хорошо или, может быть, на должном уровне. И еще очень много работы, я думаю, что на которую нужно обратить различным и правительственным, и государственным организациям для того, что на самом деле нужно улучшать жизнь жизнь людей нужно улучшать.